Hello, good evening everyone, and welcome to our webinar combined AFAP with BOFAS this evening. My name's Jodie, I'm a member of the AFAP committee if I've not met you before, and I'm so pleased to welcome Trevor Prior with us this evening to present a talk on plantar heel pain. So Trevor is a podiatric surgeon. His NHS base is at Homerton. He's got a senior clinical role at Queen Mary's sports and exercise medicine course as well, and also works in private practice. So what's so exciting about this talk this evening is that Trevor was one of the co-authors as part of the BJSM paper on plantar heel pain. Plantar heel pain that was published earlier this year. So he was part of the team screening the papers, looking at the quality assessment, looking at data extraction as part of that big systematic review. So really excited to hear his take on plantar heel pain. So just to remind you for this evening, there'll be plenty of opportunity for questions and answers. What we need you to do is to put them in the Q&A section at the bottom right-hand side of your screen. Please don't use the chat. I will keep an eye on it, but try and put all your questions in the Q&A section. Also, when the talk is finished, there will be an access code. When tomorrow you will get sent a link to a feedback form that if you use that access code, as soon as you've sent your feedback, you will get access to a certificate. So don't forget to give us your feedback. So without any more delay, I'd like to really welcome Trevor to present his talk, and then I'll come back and do some questions and answers with you at the end. Thank you very much.
Great, thank you very much. Hey.
Yeah, we've got lift off. Well done, Trevor. Thank you.
Okay, so why a best practice guide? Now all I've got to do is work out the next slide. Oh yeah, okay, there we go. Okay, why a best practice guide? Well, it was evident that from clinical practice was quite variable and often not evidence-based, and even though there's been an explosion of evidence, much of it was poor quality, and often the agreed guidelines are not followed. In this paper, looking at self-reported injury, you see that plantar fasciitis was the second most common, with 40% continuing to run and 51% not even seeking medical help. Well, I mean, 50% didn't. So what I basically did was look at the available evidence, then get experts from around the world to undertake interviews about their thoughts. The experts weren't not just treating it, looking at people that had some experience in research, and then combining that with patient interviews to get the patient experience, which then allowed us to form the best practice guideline. In terms of the evidence, we looked at all RCTs up until July 2018. They were assessed for quality with the adequate sample size determined to be 38. In terms of efficacy of an intervention, primary proof meant that the intervention was demonstrated efficacy against either a control, a sham, or a placebo, whereas secondary proof is it was efficacious when compared to a treatment that was already proven to be successful. We looked at, initially found 11,765 papers, which got whittled down to 51, which sort of talks something about the quality of the evidence. Standard forest plots were produced, and these two show the benefit of orthoses and shockwave in the short term. Efficacy was deemed positive if you demonstrated efficacy, neutral if there was no evidence of efficacy. In terms of strength, it was strong if there were multiple high-quality studies, moderate if one high-quality study, and limited if there was one high-quality study but it had insufficient sample size. We also looked at the outcomes in the short, medium, and long term, and they were color-coded as well. So in this particular instance, if you have a look at the top there, we've got evidence for the benefit of custom orthoses in both the short and medium term. But if you look at prefabricated orthoses, there was no evidence to support their use, but I'll come back to that later. Similarly, the best evidence available is for shockwave therapy, both radial and focused. But again, if we read that information, it might suggest that radial is better in the short term with focused in the long term, or I think that's probably a little bit of a leap. But clearly, the one intervention that has the best evidence is shockwave therapy. Dry needling didn't cut the mark, but both low dye taping and plantar fascia stretching were effective. And what I then did was we've got some interventions that had papers that were deemed worth reviewing, but they weren't efficacious. And then there were those with no robust evidence. So prefabricated orthoses, I said I'll come back to that. Magnetized insoles, dry needling, wheatgrass, and perhaps the surprising one is calf stretching, because I think that's something everybody commonly advises, yet the evidence is pretty weak. And if we go to no robust evidence, I guess you guys, as I think most of you are physios, will be interested that eccentric loaded didn't make the grade. And similarly, injection therapy and surgery, they've just not been studied adequately to demonstrate the efficacy. The next part was clinical reasoning. So there were 13 experts, 4 continents, 5 disciplines that were interviewed. Each interview was approximately 1 hour. There were 6 themes with 47 sub-themes. I think the main themes of diagnosis, principles of guided management, rehab, etc., is what we would expect. And then within those sub-themes, diagnosis was considered to be straightforward. There were recognition about compliance, etc. And there was also a recognition that the role and timing of rehab remains a little bit controversial. Once that had been done, the evidence and clinical reasoning were put into a kind of online information questionnaire type thing for the patients. So they did an online survey with open questions. They were given the evidence that we collected, and then it was analysed in a framework methodology. And rather like the practitioners, many of the same things are there, but you can see that they're thinking about the cause, what type of pathology they've got, have clear expectations, what strengths are there in management, their personal experience and the information they get fed back. It might be a little bit small, but they clearly had expectations. I expected to get a steroid shot and was hoping for deep tissue manipulation to break down the scarring, wasn't offered. I wrongly thought I needed insoles. As a swift recovery as possible, relief from pain and program. So they had expectations that weren't often met. And then that led into the information. If you look on there, one is the expected outcome at the end of rehab. And I'm focusing on rehab just because of the audience. Well, they clearly, what were their expectations that they do their rehab? How long is it going to take them? What's the likelihood of success? So once that information was synthesized together, what we did was we were able to look at a core approach, which we had strong evidence for. We're given some guidance about when these interventions should be introduced. So the core approach happens throughout. If there's a slow response to that treatment, then shockwave therapy is a reasonable option. Custom orthoses remain an option, with injections considered experimental because there's no significant evidence, robust evidence. And when we look at that core approach, it's basically, it focuses around plantar fascia stretching and taping, but with a high emphasis on education, which is really incorporating load management, educating people about the pain, what they expect, how they should be monitoring it, associated medical conditions, including BMI, but also the footwear component. And that's using the evidence that's available, but also what's common practice and what's reasonable, because if you think most of this is not really expensive treatment, is it? In terms of taping in my own practice, I have my patients video me taping them, I teach them how to do it, I give them information sheets, and they have to do it every day. So what about some other considerations? Well, one of the clinical reasoning things was diagnosis, and it was straightforward, but is it fair to say it's straightforward? When you look at plantar heel pain, it's a bit naive to think it's just the plantar fascia, because we've got the fat pad, we've got the fascia, we've got the intrinsic musculature, and we've got the bone. And whereas an ultrasound scan may be good at looking at the fascia and the thickness, it's clearly not accurate enough to identify those different structures. And certainly in my practice, if I have a patient that's not responding to treatment, and I want to investigate, then MRI would be my first go-to. If we look at this particular case, they've got some slight thickening of the fascia and maybe a little bit of intrinsic muscle edema. If we compare that to this patient that's got much greater thickening of the fascia with some derangement and clearly some deeper edema within the intrinsic musculature, and actually there's a little bit of edema just superficial to the fascia. Move on to this case, and if you look on the top one, you can see that's clearly far more thickening with fluid uptake, superficial and deep edema. And on the bottom one, the plantar fascia, I don't think I can, I wonder if I'll highlight if I do that. Oh, there we go. I've always wanted to do that, so I've got something out of it. If you look where I put the circle there, that's the fascia in cross section, and that should just be a thin black line, so we can see the derangement there. We move on to this. Now we've got bone edema. And in our experience, once you have bone edema, it takes longer for it to settle and sometimes needs some specific offload. We often don't worry about spurs, but we can see the spur on the right-hand picture here, just a small spur with a bit of edema. But if we look on this cross-sectional one, look at the spur here, it's pointing plantarly into the fascia, and we can clearly see some fluid where it's irritating into the fascia. So that's a slightly abnormal shape for the spur. Now that would have been there for years, so it's not something that's just appeared. So may be able to treat that conservatively. They might need a specific orthotic to help offload, but actually that may be one of the ones that might be a good surgical option. So for me, I like to use the MRI scan to help me classify the extent of pathology involved and any other stranger factors. And it can be a really good patient education tool. Moving on to orthotics, there were 4 papers, 3 of which were underpowered, but they switched the favour towards custom as opposed to off the shelf. But if we look at those papers, in the Landorf paper, they used a semi-rigid polypropylene, which is a plastic shell, and it was made to a custom orthotic made to neutral calcaneal stance position, something that's kind of that actual position has been shown to be invalid in more recent research. Whereas Robel, they didn't actually specify the material, even though they made something to neutral stance position, versus Oliveira, who used EVA Shore 35, and that's a very low-grade density EVA with a total contact inlay, so it wasn't actually providing any of what we would consider traditional support. So these orthoses aren't even comparable. Bishop, by contrast, he also used polypropylene. Just wait, I'll pull it. No, it won't come down. Sorry, you just missed the top of that. He also used polypropylene, but he detailed each individual prescription. And if you have a look in this column, actually the prescription was exactly the same for every patient. And the only thing that changed was the arch height. And the arch height changed because he took a cast to make the custom orthotic. So one wonders whether or not actually the arch height of the device is one of the important factors, not to mention the materials, etc. So that then takes on that, what do we think about how we assess the foot? And I often put this slide up, and what I'm trying to demonstrate here is if you look at the top set of pictures, that's basically a pronative foot type. The bottom set of pictures is more of a supinative foot type. But as you move to the right, you have more mobility, even instability. And as you move to the left, you have more rigidity or even completely rigid. Now, clearly, each of those foot types is going to have a different function. And therefore, we need to be cognizant of our actual arch contour, remember Bishop's paper, but the mobility of that foot. So the kind of things that can help you assess that is our relaxed stance position, because that gives us an idea about the direction of forces. Palpating the head of the talus, because that's a good reflection of the direction of the subtalar axis, which is important for how the forces are applied across the foot. The longitudinal arch angle has been shown to be a repeatable measure and fairly reflective of the position of the foot in mid-stance, so it can give you an idea about the dynamic state. We then want to consider the actual contour of the foot. I don't know if this is going to play, but we'll try. Versus that mobility. So I'm showing that's an extremely fine specimen of a foot because it's mine. But you can imagine, so I have a foot type that will lower and raise to a certain extent. It may be more rigid or more mobile from that, and that will help me guide how much that foot's likely to tolerate. Or a simple way of doing that is just have your patient stand on tiptoes and look at the difference between the non-weight bearing, the flat standing to the tiptoes to look at the mobility available. So that then takes on how do I choose my orthoses. So I use the Facility range. I'll admit I'm on the Facility think tank, but it's the one I've used the most commonly, and they have a range of orthoses that help meet my targets. So if I'm looking at someone that's got that lower arch profile with a stiffer foot, therefore it's not going to, that arch shape is not going to change much, I use a low profile device to contour that arch, and I can heat mold or add extra materials. As the foot becomes a little bit more mobile, I might move to something like the Dannenberg. It has 6 degrees of control, but a slightly lower arch profile than average. And if they have a bit of inflexibility, I could incorporate a heel lift. So that's a slightly lower arch, but more mobile. And then as we get to more standard arch, maybe a slightly higher, but more mobile arch, either the custom device or the McPoyle. For those of you familiar with foot and ankle research, Tom McPoyle was a physical therapist who did masses of research. And he calls it a tissue stress device because it has a high arch profile, but it's soft in the arch, so it allows it to give to allow some pronation. And if we're looking at a more supinated foot, if it's laterally unstable, then the Hope device has lateral posting, or if it's that kind of stiff but stable high arch foot type, and we want to spread the load or spread the love, then I'd use the McPoyle. So effectively, what I'm doing there is to try and marry the foot type and the mobility to the device, so that the patient's not just getting a standardized off-the-shelf orthotic. And most of the studies that have looked at prefabricated orthoses are just giving every patient the same device. So our principles are determine the forces you wish to modify, evaluate the arch height and mobility, consider the extrinsic factors, so calf inflexibility, poor proximal control, things that may be driving the foot, that if you stop the foot from compensating could be a problem somewhere else. Then choose the most appropriate device, but not just standard for all. So remember, let's go back to the paper and our patients questioning what actually works. Should I need an off-the-shelf orthotic? What about injections or surgery or any other treatment, right? So they've got all these questions in their head. Well, education is such an important factor because we know from the evidence that we've looked at that we have this core approach, which is simplistic and the patient should do it, it's cost effective. If they're being slow to progress, we can introduce shockwave therapy because it has good evidence for both short and long-term effect. And custom orthoses remain an option. I personally would still use off-the-shelf, but I custom the off-the-shelf to the individual. Injections and surgery remain an option, and they're there for treatment, but we have to remember that the evidence base for them is low. And when we introduce one of these will very much depend on the previous experience of the patient, the level of pain they've got, their activity levels, etc. So some patients, I might offer them an injection early on, but tell them if they just rely on the injection to sort out their problem, they'll be lucky if that's the case because it could well come back. And obviously, we need further research looking around the prefabs. Rehab in particular, you guys, I'd encourage you to get out there and do stuff because at the moment when you give them that eccentric program, you've got very, very weak evidence, if any, to prescribe it. And certainly around the injection therapy and surgery, and overriding it again is patient education. Thank you very much. We did it.
Thanks, Trevor. Thank you very much. Really interesting talk.
I'll see if I can stop that share. Come off here and then go back to, sorry, bear with me. Okay.
So while you kind of
done.
Stop sharing your screen.
Start my video. Yep, go on, far away. I'll see if it start my video and then it'll let me do that. There we go.
This is the benefit of being one of the moderators, is that I can ask my questions first. So one of the things that you said at the beginning is that there was evidence that calf stretches don't have any efficacy, which really surprises me because, as you say, it's something that we probably all quite naturally give to this patient cohort. So can you remember, I mean, obviously there were so many papers that you all had to trawl through. Is it that the papers showed that they weren't effective, or were they not well powered enough, or is it that we've not ever looked at them in isolation to be able to get that information?
Yeah, I think you're right. So there were some papers. They were in that group that had papers that were reviewed, but they just weren't strong enough, right?
Yeah.
So it's not, what you have to consider from all of this is you've got eccentric exercises, plantar fascia stretching, prefabs may be efficacious. It's just no one's done a robust enough study to demonstrate it, right? Or the ones that they have done are too weak, right? Or they don't show significant enough change to give you that benefit. So if you said to me, do I still give my patients calf stretches for plantar heel pain? And notice I said plantar heel pain and not plantar fasciitis. Yes, I do. And I do that because over the years, enough people have found it help. The calf obviously goes into the Achilles, and there is actually a direct link through to the fascia. When you stretch the calf, you often stretch the fascia. And if we consider that we think that abnormal load onto the foot, whether it's a pronatory force, an early heel lift, whatever it happens to be, may contribute to overload onto the fascia, then stretching the calf muscles is a relatively straightforward thing to do. It costs nothing. It virtually never does any harm, and it gets the patient involved in that process. So I think it's just, when a patient's talking to me about the evidence, I tell them what the evidence is, but say, look, we'll still do this and we'll do it for this reason.
Yeah. And then kind of linked to that, so we have got evidence from your practice guideline about stretches for the plantar fascia itself. Are you able to kind of describe what stretches do you tend to give them as well as the calf stretches?
Well, I've had to change it now we've got the paper, because the paper that sort of showed it, if you look at it, what you effectively do is you dorsiflex the toes, the MTPJs, with one hand, and then you kind of grasp the heel and fat pad and pull the fascia in the other direction with the other hand.
Okay, so is that like the Giovanni kind of stretch from that kind of paper?
I'd have to look. I'm not very good with names.
I think so I'd say passively dorsiflexing the toes and then using your hand.
So you're putting the fascia onto a stretch.
Yeah,
and then using your hand to pull the other way. I mean, I think the reality is if I used to get people to stick their fingers in, so stretch the fascia and then stick their fingers just anterior to the fat pad. So you're kind of doing it almost like a deep friction type thing. And I often get no evidence for it. I often get my patients to freeze a bottle of water and use that to massage the fascia. So, I think in reality, I don't think we could say you have to do this stretch compared to that one. I just decided that I would do the one that was in the paper because I thought it's probably appropriate to do that.
Yeah, and certainly the ice bottle seems to give them symptomatic relief, doesn't it?
Yeah, but there's no evidence for it. But again, it's a free treatment. It's easy for them to do. They do it every evening, and so you've got 2 or 3 things, because our battle, what I haven't really discussed there, is the battle around footwear, and that's often the biggest battle. They don't sort out the shoes; they're onto a hiding to nothing. So if you can get them doing some things and then kind of encourage the shoes around that, then at least you're starting to get them on board.
Okay, great. Got a question from Pauline. Can you remember, was there any evidence in there, any papers at all for any joint mobilizations, either of the the STJ, the subtalar joint, anything at all that you came across?
No.
Nothing at all. So there you go, Pauline. That's your study. You get that design. I think that's the trouble with all of this.
Yeah, I think, but you've got. Well, I think if you look at it, just think, if you think about your patients with plantar heel pain, I'll go back to plantar heel pain because you've got a range of conditions you're going to be treating, right? Not just the plantar fascia. But if you go back, you've seen people with every foot type that have had plantar heel pain. And therefore, there isn't one factor that gives you plantar heel pain. It's multifactorial. Therefore, when you tell me you can actually diagnose how restricted a joint is, you can mobilize it to get within a normal range. Well, you probably don't have a normal. You'll have a range of motion that theoretically you can measure with a goniometer, but probably don't have a normal range, or not one that's repeatable. And you don't know the influence it has on the foot function. Therefore, actually doing a study that demonstrates one treatment like that makes a difference is very difficult. You would have to literally say, I'm going to do subtalar joint mobilizations, or have a protocol that tells me which joints to mobilize, so somebody else could follow that with the same patient, and then do the joint mobilizations, do nothing else, and compare it to something like shockwave therapy.
Yeah.
Right? Because we know that works. or they all have the standard treatment except you just changed that one thing, right? And I just think that would be a really hard study to do.
Yeah, I agree. We've had a few questions come in from Terence and also Tim and Susie, kind of all around the timings of when you think, when would we start to consider shockwave? When does it become recalcitrant?
Okay, so my standard process would be someone comes in to see me with their heel pain. It might be a new patient, it might be someone who's had it for ages. I review the core approach and I make sure that they've changed everything they need to change so they're doing the core approach, right? And I'm anal about footwear, right? I will tell you now, 90% of the people you see will be in the wrong size shoe, even if it's the right shoe. So they have to change the shoe size, right? They have to get in the right shoe. And what I've started telling them is that they should consider the shoe as a tablet with no side effects. Because if I told them I'd give them a tablet for 4 months that would get rid of their pain and it'll be gone for good, they take it. Right, well, take the tablet. You might not need it for the rest of your life, but you should tab it for the next 4 to 6 months, because by the way, that's how often it takes to get over the problem. Right, and there will be no side effects from this tablet. Right, so you have to get on board. I will then review them at 6 weeks. If they're not making enough progress, and that's determined by both them and myself, that's when I consider shockwave.
Okay.
Right, I think 6 weeks. You could probably go to 4 weeks. Yeah, but it will also depend. So if they've done everything else and they come in and they've already done it all, then I might consider the shockwave earlier. Right. Similarly, if they go, oh, I'm 50% improved, I think it's still getting better. So well, what do you want to do? They go, well, I'm happy to carry on. All right, we'll carry on.
Yeah. And also, is there a standard protocol that you use for shockwave for plantar heel pain? What's your kind of general guide?
Yeah, so there is. There is, although you have to appreciate, I don't do it very often myself now, partly because in the NHS it gets done by a particular team, and privately the insurance companies won't pay for us to do it. So you guys get all of that work. But if they're going to somewhere I haven't used before, I do try and talk to the physios, because I like to do 2,500 impulses, 10 hertz, and then I'll start them off low. It's the storts and stuff, so it goes up to 4 bar. Mm-hmm. I get them as high as I possibly can. I'll get them up to 4 bar if I can. If they get to a point where they can't tolerate anymore, I just stop at that point. I tell them, well, we didn't quite get there. Next time they want to get as high as they can. So we do a treatment once a week for 3 weeks, get them as high as they can on each one of those, and then see them at 12 weeks. Okay.
Great. Question from Louise, looking more about kind of diagnosis. So you mentioned that you find MRI useful, but she's just questioned, when do you think ultrasound may be beneficial over MRI, just because of the long waits that patients may have for an MRI? Is it still useful?
Well, I think ultrasound is useful if you have it in the clinic and you're going to do it there and then.
Yeah.
Right. I mean, referring, unless you think you might have a fibroma or a tear, right, then obviously the ultrasound can be done. But just they got plantar heel pain and is the fascia thickened? I'm not sure there's much of a point to that. The only point to it is if your trust or where you're working say you need to have some kind of investigation in order to do shockwave, right? So they'll give you it's 5 millimeters thick, it's got plantar fasciitis, so you could do the shockwave. There's an argument for that, right? There would be an argument for that. But then you might as well get one in clinic and do it yourself.
Yeah.
Right, so look, and I'm not, everybody practices. I'm not saying you should all go out there and MRI everything. I mean, if you're working in an orthopaedic or rheumatology team, they'll probably pull their hair out if you said that. So you've got to be judicious to a certain extent, right? But part of the MRI is patient education. Right, and it's like, look at this. Not only is your fascia thickened, look, it's a little bit deranged here. You've got inflammation in the muscles and your bones inflamed. You're wondering why it's hurting. You still want to do your 20,000 steps a day. There is a patient education in it.
Yeah.
So I'd probably be a little bit more judicious in the NHS than privately if I was going to be perfectly honest. But if I've got someone that's not responding and I want to know the extent of it, and the bone edema is the key thing for me. If they got bone edema, I just know it's going to take longer.
Yeah, helps with that education then, doesn't it?
Yeah.
Okay, I've got a couple of questions. Taping. Sorry, Trevor, interrupted.
Yeah, I was going to say I had a patient who saw me once and I told her what she needed to do. And she said, well, I'm not going to do that. I went, okay. So the conversation went somewhere along that lines. I was beginning to internally lose it. I'm pretty good with patients. And then she opened the door and said, what would you say to me if I was your wife? So I said, if you don't want to know the answer, don't ask me the question. Do what you want, but when you come back in 6 weeks, don't bitch to me that your foot still hurts. So she comes back 6 weeks later, how you doing? My foot still hurts. Did you do what I said? No. Or what do you want to do then? She goes, all right, what was it I have to do again? So eventually they come round.
Yeah, yeah. We've had a couple of questions come in around the taping. So obviously there's loads of different tapes that we can use. So was there evidence really between different types? So the kinesio tape, more the rigid tape, and then you obviously mentioned the low dye taping. Was it the low dye taping technique?
It was low dye. It was low dye taping. Yeah.
So with
low dye
taping.
taping. Yeah.
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 So actually, Ian Griffiths has got a really good video of how he does low dye taping on YouTube. If you're not sure, kind of Nihar, what that looks like. And do you ever use that as a?
There are various ways of doing low dye as well, and I use a modified low dye tape. But you've got to. I choose one that I know the patients can do, right? Because I tell them that. I often say to a patient, if you do everything I tell you to do, this could take 6 months. We hope it won't, but it might do. But you've got to do everything. You've got to keep on doing it. You've got to hang on in there, and you're over it when you can press your heel and it doesn't hurt. Mm. And so I show them how to tape. I get them to video it. I give them a separate sheet with it, along with the other exercises. And I say, take it off at night, have your bath in the morning, spray with Opsite, put it back on. You've got to do it every day. And I would tell you the single biggest thing that makes a difference to the patients. If I put a low dye tape on someone's foot and it doesn't feel better, I'm like, okay. I need to think about this patient a bit more, think about the condition slightly differently. It's that uncommon for it not to make any difference.
And anecdotally, do you find that's a good treatment directive if they then find the orthoses beneficial? Do you ever use it for that?
Yeah. 100%. I mean, a lot of people do that. They use that as a guide, say, if this helps. And actually, you know what? Often the orthoses don't work quite as well as the tape, just because of the way that the tape and the proprioception. But I won't necessarily, if they're doing really well at 6 weeks and the foot type's not that bad, I don't rush them into orthotics. You know, but if I assess them, they've been everywhere and orthotics is something they haven't done, or if they've got bone edema and it's not settling down, we might do a custom orthotic and we put a little dell where it's painful, and it's never where they make them and it's in the middle of the heel cup. It's never there. If you press and get the most painful, but draw a circle around it and stick them on orthotics, it's always in the curvature of the heel cup. So that's where we put the dell. So they're not walking on that bit of the heel cup.
So it's all offloading again, isn't it?
Exactly.
Yeah. Okay, so we've had a few questions in about the loading. So kind of the Michael Rathleff paper that I think probably most of us are familiar with that he did showed that the heavy slow resistance for plantar fascia. So I think he was one of the co-authors, wasn't he?
Yeah.
So what was did he have any opinions about his paper not being included? What was his reaction to that?
Well, to be perfectly honest, I can't say we all sat around the table and had discussions around it. There were some email exchanges and stuff like that, but he's a scientist, isn't he?
Yeah.
All right. So the paper didn't meet the scientific criteria, so there isn't really any argument with it. But I spoke to a physio team last week about Shockwave because I just wanted to know what their approach was because I like people to crank it up and say, yeah, and we also give them the eccentric exercises. I didn't have the heart to say, well, you've got no evidence base for that. I did want to say, well, maybe you should read this. Well, actually, when I wrote to them, I said, you might wish to read this paper. So again, I spoke to Michael about this a number of years ago. And one of my things was when a lot of these studies are done, you don't know what you're treating. Right. His view was that with their sampling that they would even out what the pathology actually was. So we won't know either way. He did sort of say that it seemed to be a little bit more efficacious from what he'd observed with people that are a bit more sporty. So I'll tell you where I sit with it. It is not a standard part of my treatment. Right? It's not a standard part of my treatment by a long shot. But if I've got a runner or sportsman that's suffered with it, they've not run for ages, then I have no problem them doing the eccentric loading program because in my mind, what they're going to do, they will be doing some calf strengthening while they're doing it anyway, and they'll be loading the fascia, getting it ready for more load, right? So it's more of a kind of return to load treatment than this will get rid of your heel pain.
Yeah. So you still need your core, but it could be part of that load management plan to get them back to running.
So it's a return to play treatment in my mind, as opposed to a plantar heel pain treatment. So a bit like, I don't know, what can I think of an analogy if you got a tib post tendinopathy, right? What are you going to do? You're going to offload it, you get everything in place so there's no load onto the tendon, right? And then you build up slowly, don't you? But you're not going to allow them to go back to activity till you get them doing really good heavy loading, isometric loading, maybe some plyometrics. But you won't go, you've got tib post, I'll get rid of that by giving you plyometrics.
No, that wouldn't work, would it? Okay.
Right. So to me, it's a return to play for those people that need it. So Joe Bloggs, if I've got someone who's, I don't know, 120 kilograms and whatever, I'm not convinced if I have much effect on that at all.
You mentioned isometrics there. Can you remember, was there any evidence around isometric loading of gastrocnemius, soleus, or plantar foot muscles? That question's come from Nikki Sherman.
So, yep, I know Nikki. So, if the intervention is not in the paper, there were no papers of sufficient quality or evidence for the intervention.
Mm-hmm. So it wasn't there then.
And remember what I said to you as well, is that the way we divvied up the papers were kind of A to C, D to F,
yeah.
G to, because there were like, so many papers. So we all took a whole section. So you weren't necessarily getting, you looked at one condition and someone else looked at another, because we were looking at the papers objectively, irrespective of what the intervention was. Mm-hmm. So it was, one, was it an RCT? Two, did it have a control or not? Was it sufficient quality, et cetera, et cetera? So the actual intervention was less relevant than the quality of the paper and the evidence that was performed. Now, clearly in ours, we had if you're doing R and you do romp, you get loads of shockwave papers, right? So if you're doing C and Cotchit, you would get dry needling. And so obviously if an author's produced a lot, you might see a load of those. But effectively, it was a big bit of work, and it was fairly ruthless, and said, if you don't meet this standard, then there is no sufficient evidence for that treatment to be done, right? Does it mean you can't do it? Well, of course not. But
yeah, it's clear that it was diligent, wasn't it? The process they all went through.
Yes.
Yeah.
And so, we've just talked about calf stretches, right? And calf stretch is such a common thing for people to advise. It costs nothing. It's a daily thing for the patient to do. They don't have to come and pay to be treated to have it. So there are no kind of conflicts of interest in giving someone a calf stretch.
No, that's great. No,
but if you have to come and have a treatment, 3 times a month, but the evidence base is weak, then there's almost a conflict of interest there.
No, that's been really interesting. So I'd encourage everyone to read the paper. It's really comprehensive, but actually is still, it's the process that you went through was really clear in there to help us all understand why some papers, that we may know of weren't in there. So I'd encourage everyone to read it. It's open access, isn't it, in the BJSM? So it's not behind any paywalls. So definitely, if you just go on Google Scholar and search for best practice guideline for plantar heel pain, it's pretty high up the list there. It was published. Yeah, earlier this year, wasn't it?
This year,
yeah.
I think it was May, wasn't it?
Yeah.
April, May. So, I have to say, in fairness to the BJSM as well, the review process was really, really thorough. I was like, wow. Right, and I review papers, and what they did with that paper was just massive. They picked up on so many things. So it was quite satisfying to be part of it, actually.
Yeah. Well, thank you very much. We haven't quite managed to get through all the questions, but I think I've managed to pick out the main themes. So thank you everyone for sending them in to us. And thank you, Trevor, for your time this evening. Sorry about our IT challenges at the beginning.
It was my IT. It was all my end. All my end.
But no, I've thoroughly enjoyed it. So thank you, everyone. So remember to look out for your links tomorrow for your feedback questionnaire. And then once you've sent that back in to Joe, then you'll get your automated certificate back. So thank you, everyone. Enjoy the summer. We're going to have some time out now, and we'll come up with a plan as to what we want to do in September going forward. So we'll let you know via email. So thank you very much, everyone, and enjoy the sunny evening.